I'm Dr. Larry Santora, and welcome to Health Matters. On today's show, we'll take a look at green tea, black tea, and chamomile, and we're going to examine which of these is the healthiest. And Dr. George Morrow will join us later to explain colon cancer and how it affects both men and women. But right now, our first topic is eyelid surgery. Many people develop puffiness and wrinkles around their eyes. My guest is Dr. Howard Kahn, who is a laser cosmetic surgeon in Irvine. He specializes in eyelid surgery. Thanks for coming, Howard.
Thank you.
You know, what happens when we age? What happens around the eyes here? What is going on? What's the process?
Well, when people get older, 30s, 40s, 50s, they tend to develop loose skin around the lids, and also there's sun damage, which will cause wrinkles around the eyelids. Also, there's a great hereditary component where no matter how much exercise that a person does, they'll look tired because somebody in the family had some bags under the eyes, which is fat that's come forward.
So the fat's there all the time. It's not that the fat is deposited as we get older, but you have this fat here and it just comes to the surface, it's deeper down?
Yeah, I think the fat will come to the surface, and also the overlying tissue will tend to thin out, which will cause the fat to have the appearance of puffiness.
Okay. And the darkness under the eyes, what causes that?
Well, the darkness can be a combination of things. It can be fat that's come forward. It can be pigment on the surface that we address with some of the lasers. And it also can be actually loss of fat in the inner portion of the lower lid. And with that, we actually fill that with material.
I see. So as an ocular surgeon, this is your whole bailiwick. You specialize in this. You've been specially trained in this, unlike other cosmetic surgeons who may do just general cosmetic surgery. This is what you really focus on.
Yeah, my specialty is eyelid surgery, and I have trained in general surgery, but also I'm board certified in ophthalmology and have fellowship training in just the ocular plastic surgery. So that's basically what someone with my training does all day, is eyelids and related things.
So what happens, explain to us, what happens during the eyelid surgery?
Well, I prefer to use the laser for these procedures, and I'll just show you an example of a patient who had surgery of the upper and the lower lids. And we do these in the office with local anesthesia. We cover the skin with some ointment to numb it up, so when we give the local anesthesia, the patient doesn't feel the local. And we place protectors over the eyes, and instead of using a scalpel, we use a laser to make the incision. And this is a diagram of the kind of procedures that we do where we remove skin and fat. So we draw a line where I want the lid crease to be, a second line to include the redundant skin. And instead of using a scalpel, we use a laser, and this is a handpiece for a CO2 continuous wave laser, and it makes a tiny little beam of light, and this beam of light will seal the blood vessels as it cuts. So that's the advantage over a scalpel, that there's not bleeding. So the surgery is done faster, and people have usually very little bruising.
Now, we recently went to your office, and we're going to show some patients that you did the procedure on.
Hello, how are you?
Hi, nice to meet you.
Bonjour, bonsoir, bonsoir,
Yes. I'm hoping to look like her when I'm
Yeah, isn't that terrific?
Yes, wow.
Good.
Good job.
So, would you like to come with me?
Yes, please. See this?
Yeah.
Okay, now if I pull it, it can get really bad sometimes.
Right,
So,
okay. So let me take
see,
a
it's
look.
just starting, but I'm getting...
So let me take a look right here. With the upper lid, we draw a line right here,
Okay.
and the second line to include some redundant skin. And then I use a laser with a 0.2 millimeter spot size. It's a little beam of light that cuts, and it seals the blood vessels as it cuts, so there's no bleeding. And then we close that with sutures. And the sutures stay in for about 1 week.
How much can you get rid of on this?
Okay. Well, let me just show you in the
Okay.
mirror. With that, I would not surgically take any skin, but I would use this laser to tighten up the skin. And I'll show you that laser in just a second.
Okay.
The other thing is, you have this line right there. And you see that little kind of it's like a little dent right there.
Yes.
With that, I fill that with some Restylane. You can see how it softens that up. You mentioned Photoshop, and it looks like a Photoshop.
It sure does.
But this is what I've done with her, because she had a really deep line right there. And to show you how this works, there's some areas that are not treated, so those little cells will seal up the tiny little holes.
Okay.
And that's the whole key. So that's the story.
All right, thank you, Dr.
Oh, you're welcome.
I look forward to looking better.
Oh, thank you. You already look better.
No, it looks like, I mean, you have, with the laser, that you have less bleeding, so you have less bruising, I guess, and so you get back to work faster. And the other laser that you demonstrated there was the Fraxel, right?
Right.
And is that what you have on the table there?
Right. The other modality of lasers that are used in eyelid surgery have to do with tightening the skin and reducing the brown spots. And there have been other lasers throughout the years that have done this, but the present modality is called the Fraxel laser, and this is the handpiece that where the energy is applied. The machine is attached to this disposable handpiece, and the laser, we glide the laser over the area that we're treating. It can be the eyelids, the face, hands, neck, chest, and it puts tiny little spots of energy in, and the adjacent skin will seal up those little holes, so the healing takes about 48 hours. And so there's less risk of infection with this procedure.
So you're saying to me that years ago when they did with, well, I guess they still do it that way with traditional cutting and stuff, their downtime would be quite extensive, wasn't it, after?
Well, when I used a scalpel, I used to tell people, and I used a scalpel from about 82 till 92, and I've used a laser since about the early 90s. And I used to tell people to expect to be bruised for several weeks.
Wow.
And now I tell people 3 or 4 days.
Huge
So
difference.
there's certainly the downtime advantage. Then the other advantage is this technology of shrinking the skin with these fractional lasers, because in the old days, which was not that long ago, 10, 15 years, all we could do was pull the skin. So we can now address the sun damage element where the skin can be tightened at the same time. And all these are done with local anesthesia.
This is a quantum leap in improvement, I mean, compared to what you described before. Can you do the upper and lower at the same time?
Everybody's different, and sometimes people need just the upper, just the lower, sometimes just resurfacing. So everybody's different, but we'll often do the upper lid surgery, lower lid, where we'll remove a little fat from the lower lid, and the laser tightening all at the same time, and that combination takes about an hour.
So you can get rid of the droopy eyelids up here, get rid of the wrinkles on the side, get rid of the puffiness underneath in an hour.
Yes.
And get back to work in?
Well, 3 or 4 days usually.
Wow.
The sutures in the upper lid stay in for about a week. There are no sutures in the lower lid, and of course with the laser tightening there are no sutures there also.
That's amazing. So this is really, it sounds like your business is only going to grow as we all get older, and not that it's simple to do. I would think that there's not too much room for error here, and I would think that somebody wants to really work on their eyes, they should see somebody who's trained in ocular surgery like this. But this is really fascinating that you can get back to work so quickly and work in all these delicate tissues and get such a great response. I know you've been a pioneer in this. You've been doing this for many.
Well, I started
years.
using lasers when I was at Johns Hopkins in 1978. I've worked with laser companies to help develop some of these, so it's a lot of fun to have these new devices that actually work and are safe.
Wow. Well, we're running out of time now. That was very interesting, and I appreciate you coming on, and I think a lot of people are going to seek out your expertise.
Thanks for having me.
We'll be right back. Later in the show, what you should know right now about colon and rectal cancer.
Fact or fiction? Swallowed gum takes 7 years to digest.
This is definitely fiction. Gum does not take 7 years to digest. It's quickly liquefied by the stomach acid. Welcome back. Each week we look forward to receiving questions about health and wellness from viewers like you. And it's time to tackle today's question.
Hi, Dr. Santora. I'm Amy from Orange, and here's today's question. I drink a lot of tea. Is there any difference between the health benefits of black tea, green tea, or herbal teas?
Yeah, there is a difference in teas, but some of them are not really teas. The traditional tea that we talk about really comes from the same plant. It's an evergreen tree, and whether it's green or black or white tea, it comes from the same exact plant, and it's just how you process the tea. This is a green tea leaf, and it's not oxidized as much, and it's not fermented as much. The black tea is fermented more, and it comes to a darker color, but actually it's the exact same plant. And we think the medicinal purposes and the health benefits from the tea, green or black tea, is probably the same despite the hype that we hear about it. There's not a lot of research on tea, believe it or not, even though it's the main beverage in the world. The teas in general have properties of anti-clotting properties. They can lower your cholesterol. We think they may have some properties in preventing cancer. They do have caffeine in, about half the amount of coffee, so about 40 milligrams of caffeine per cup. But they're really the same plant. Now, chamomile tea is really not a tea. It's made from a daisy-like plant, and it does not have caffeine in it. So that distinguishes it from the traditional teas. It does have relaxing properties, relaxes muscles. It takes care of menstrual cramps. It can have some anti-inflammatory, antibacterial properties. And we think it maybe prevents some of the complications of diabetes. So tea is black tea, green tea, white tea are all from the same plant, and chamomile is really an herbal tea. Any of them they all have benefits. You may choose one over the other, but the research is really out. So enjoy whatever you like, but if you want to relax, you should take chamomile because the other teas have caffeine.
Fact or fiction? Wearing a tight hat causes hair loss.
Fiction, but wearing hair pulled back too tightly or in a tight ponytail or cornrows can cause hair loss. Colon cancer and rectal cancer affects both men and women. Here in the United States, more than 50,000 people die of one of these diseases each year. Our next guest is Dr. George Morrow. He's the co-medical director of the colorectal program at the Center for Cancer Prevention and Treatment at St. Joseph's Hospital in Orange. George, thanks for coming.
You're welcome, Larry.
So how common is colorectal cancer in men and women? Is it equally divided, or?
It's pretty close to equal now, Larry. It used to be more men than women, but it's pretty much equal.
Is there any reason for that we know of?
I think probably better screening in the men, so we're picking things up earlier, preventing cancer.
So how many do you think we pick up a year now? How many, I know 50,000 die each year. How many people are?
We probably still pick up about 150,000 cases of colorectal cancer in the United States on an annual basis.
Yeah. And so it's probably is a disease of the older population. The older you get, the more likely you're going to get it?
It is more likely, though we still see it in fairly young patients.
So when do you start screening? What ages do you recommend screening?
Screening should start in the average risk patient at age 50. Or if there's any risk factors, such as family members that have colorectal cancer, should start at age 40, or actually 10 years younger than the youngest relative that had colorectal cancer.
Oh, is that right? So if your dad had it when he's 75, you should have it when you're 50?
When you're 50, correct.
When you're 50. And so there's a lot of screening modalities. There's blood tests and a whole bunch of other things. What is the gold standard for screening today?
For screening in the asymptomatic patient with no problems would be colonoscopy.
Yeah. So the colonoscopy, you need to go all the way around, right?
That's right.
And so the prep is?
The prep is probably the most uncomfortable part. It's notorious, but there are better preps now that are less difficult for the patients, and so it does a very good job.
And are the scopes smaller than they used to be, or?
They actually are. I mean, they're still talking about less than a half-inch diameter, but they're getting smaller.
So what about other things like a rectal exam with your finger or stool for occult blood? Are they substitutes for colonoscopy? Or?
They're not substitutes at all, but a rectal exam should always be done because you can always put a scope past the tumor without feeling it.
Oh, so before you do the colonoscopy, at the time of the colonoscopy, you still stick your finger in.
Always put your finger in.
And check it in. And are there blood tests that work for this, or any genetic testing that's helpful?
There are no screening blood tests for the asymptomatic patient. There are genetic tests that we're doing. For instance, if somebody has a relative who's had colon cancer, there are some screening tests, genetic testing, to show that they are at increased risk to develop cancer. They may not get it, but they are definitely at increased risk.
Okay, so you get that test, and what would you do, screen more frequently, or you wouldn't take out the colon prophylactically ahead of time, would you?
Not in that situation. You would screen more frequently than the person who, say, for instance, doesn't have that genetic trait.
Yeah. Are there new screening modalities on the horizon here?
There's a new test called the virtual colonoscopy or colonography, which is basically a very specialized CT or CAT scan. It does actually a fairly good job. It has its limitations. One of the limitations, it can't do anything about anything it finds. But for the future, what we're looking forward to is being able to do this on a more frequent basis for the patients and get more people involved, because it's quicker and easier and doesn't require the sedation that you do for a colonoscopy.
Yeah, so the preparation is the same, but the actual procedure is less painful and less risky,
Yes.
I imagine, right?
Yes.
Now, if you were thinking you had colon cancer, I mean, what are the symptoms you would have? I mean, how often do you have symptoms?
Well, we hope that people don't have symptoms, because generally symptoms means it's more advanced. But the typical things, for instance, rectal bleeding, although the most common things for rectal bleeding are benign things like hemorrhoids.
You mean bright red blood?
Any type of blood. The bright red or dark red is not indicative of cancer or hemorrhoids. Any blood is considered cancer until proven otherwise. So if you have any rectal bleeding, changes in bowel habits, and not just like a 1 day or 2 day, but something persistent. And that could be decrease in the number of bowel movements associated with bloating. It could be increase in bowel movements, because only small amounts can come out at a time.
So, George, if you have any of these symptoms, do you wait and see if they get back to normal after a week or two, or do you say, hey, things have changed, I want a colonoscopy right away?
If you have these symptoms, they last a day or two, it's probably going to return to normal. That's okay. If the symptoms persist, the first thing to do is come to the doctor's office and get an examination. Most rectal bleeding is benign. You can do a digital examination, a visual examination, and then a sigmoidoscopy in the office, say, for instance, for rectal bleeding, and you'll make the diagnosis right there in the office without a colonoscopy. The difference is diagnosing symptoms versus actually doing screening in the patient who has no symptoms.
Now, another thing is, a lot of people don't know this, but if you have dark stools like tar, what does that mean?
Well, generally, tar-like stools are usually bleeding from the stomach or something above the colon, generally not from the colon.
So you would maybe start with upper endoscopy
Upper
first,
endoscopy.
rather than colonoscopy. Now, when you identify colon cancer, do you always have to open the abdomen up, or can you do it differently?
Well, that's been a big trend in the surgical treatment. Most of the surgery we do now is done laparoscopically. It still requires a small incision, about 2 inches. You have to get the colon out, so you have to make somewhat of an incision to get it out. There's been 2 international studies that were completed about 2 or 3 years ago, which showed that the results of laparoscopic surgery for colon cancer was equivalent or maybe even better than doing it open. So there's basically all of our colon surgery now is done laparoscopically.
Have the survival rates increased with colon cancer?
On a stage-for-stage basis, no. But we're seeing better survival because we're catching people at earlier stages. And that's the whole goal of screening, is to catch people with polyps, or if they have cancers at very early stages, which overall would increase our cure rates.
So a lot of these, if it's localized, you can just take it out and you don't have to give any chemotherapy. Is there a certain percentage that don't require chemotherapy?
That's right. Depending upon what we call the stage, if it's an advanced stage where it's spread to lymph nodes or beyond, yes, chemotherapy. If it hasn't spread to lymph nodes, most of those people don't need chemotherapy.
And so for a simple, if there is such a word, for a simple laparoscopic colonoscopy for a confined tumor, how long are they in the hospital now?
Our average stay is about 3 or 4 nights.
3 or 4, that's it. Compared to what was it before when you opened them up?
Well, probably 6 to 7 nights.
And what is the future for chemotherapy? Is any new types of things on the, immune type therapy or?
Actually, chemotherapy has evolved in the years that I've been in practice from one drug that didn't do a very good job now to 3 different drugs. Fortunately, they're not very toxic, but the benefit is huge. We are increasing cure rates by easily 50% or better.
Wow.
There are some drugs on the market now that are actually being used that are even showing greater promise in just completely eliminating these tumors. There's going to be things like immune therapy and vaccines that will be coming out in the future, probably not the near future, but the progress in treating colon cancer and rectal cancer with other things than surgery is really very much in the future.
So right now we don't have a vaccine, but is there investigations going on with the vaccine?
There are, but it's something that's very much still in the laboratory.
That's good. So if you had to leave one message today for people at home, what would it be?
Colon cancer is preventable because you can find polyps. Polyps are benign. As they get bigger, they turn into cancer. If you do a colonoscopy, you can remove the polyps. No polyps, no cancer. And just doing that on a regular basis, not every year, anywhere from 3, some people say even up to 10 years, but at least 3 to 5 years, doing a colonoscopy, you can almost eliminate this disease.
And that holds for men and women.
Men and women, absolutely.
Great. Thank you so much. We're out of time. That's a great discussion. Appreciate it very much.
Thank you for having me, Larry.
Thank you so much for joining us. Be sure to send us your questions. Our email address is healthmatters@chapman.edu. I'm Dr. Larry Santora, and remember, your health matters.
So there's a little papilloma here, which we're going to remove. Then you'll be perfect.